This episode is brought to you by... Oops, I've got a box of Cheez-It crackers staring at me and I just wanted that irresistible cheesy crunch. Sorry, that was a total snacksident. What was I supposed to be talking about? So salty, so crunchy, so cheesy. Whoops, lost my train of thought. I've heard of brain freeze, but brain cheese? I'll just have one more Cheez-It cracker and then I'll get back to it.
Meet the computer you can talk to. With Copilot on Windows, working, creating, and collaborating is as easy as talking. Got writer's block? Share your screen with Copilot Vision to help spark inspiration, and use Copilot Voice to have a conversation and brainstorm ideas. Or maybe you need some tech help. With Copilot Vision, Copilot sees what you see. Let Copilot talk you through step-by-step guidance so you can master new apps, games, and skills faster. Try now at windows.com/Copilot.
This is Addiction Medicine Journal Club. I'm Dr. Sonia Del Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. Don't forget, this podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we are going to be discussing misuse of prescription stimulants. So, John, how are you doing tonight?
I am living the dream. How about yourself? Getting ready for Thanksgiving coming up here. We're 2 nights out.
Yep, we're getting ready. Love Thanksgiving in South Central Pennsylvania. Not only do we have Thanksgiving, I have turkey pickup day where I get to drive to the farm to pick up the turkey that I ordered, several months ago.
Yeah, and this is like first world problems, but we're getting my kitchen renovated, and it was started in August, and it was supposed to be done like 6 weeks ago, and it's not going to be ready. So still like eating out of a crock pot for 3 months straight now, like MSG levels through the roof.
What are you guys doing for Thanksgiving then?
I'm going to my parents.
Perfect. They're probably thrilled.
Nothing like being 40 and Mom, can I come over to your house?
Yeah, it's awesome. I'm still mooching off some of my parents' like subscription services. So, I mean, I pay my own cell phone bill now, but let's just say I'm still like mooching off Amazon Prime and some other things for my parents.
Yeah, I feel like when I do my like 20 to 30-year-old physicals, there's not really a medical reason, but I often just ask them like, do you pay for your own cell phone? Okay, I'll like pay for your own cell phone bill and just see. I'm amazed. Most people don't at that age.
Oh my gosh. Oh well. Someday that'll be us. We'll be paying cell phone for our kids and they'll be like 40.
Yeah. Well, yeah.
So John, what do you want to tell our listeners about addiction in the news this week?
I like one of my favorite reading is Stat, and so they have a nice article about it's called "Tobacco Use Binge Drinking Because Americans Consume More Marijuana" survey finds. And so it's basically the results of the 2024 National Survey on Drug Use in the Health, so the NSDUH. And just to give like a little bit of background, this is a national or federal benchmark regarding kind of assessment of prevalence of both mental health and substance use disorder in the United States. That's conducted every year. This is kind of a very special NSDUH survey because it's actually the first one since these widespread cuts from HHS. So I think they were kind of worried it would even get here at one point. And I thought some interesting trends in consumption and mental health in the United States. As we've talked about before, marijuana really is on the rise quite a bit. And not only is it on the rise, but what we're seeing is on the flip side, the generation where it's on the rise, they're drinking less. So binge drinking is down, tobacco use is down. And in the past year, 48.4 million Americans, that's 16.8%, had a substance use disorder that met criteria in the past year. So that's pretty high, almost 1 in 5. No surprise, most common was alcohol, marijuana, opioids. Marijuana use was the one that they talked about that was on the rise. It was 6% last year, now up to 7.1% in any American over age 12. So that's pretty high, like 1 in 10 again. Alcohol use disorder rates were decreasing, while opioid and stimulant use disorder remained largely stable at 1.7 and 3%. And drug-related deaths declined. So 78,000 Americans died of drug overdose in the past 12 months, which was down from 110,000 in the late 2023. So that's good, although I'm still surprised. That's still a lot of people, 78,000.
Yeah,
I mean,
that's a lot.
are you surprised about that number?
I mean, no, I don't know. I feel like drug use is pretty high still. Like things have been looking up a little bit, but I don't know. Just on the ground, it's so high, you know?
Also, only 17% of Americans with opioid use disorder receive treatment with any form of medication. So, less than 1 in 5 is actually getting evidence-based care in terms of their opioid use disorder. And then, on a side note, we're not a mental health podcast, but I mean, there is a lot of intersection here. They talked about mental health trends. So, fewer adolescents experiencing depression or suicide attempts, and adult depression and serious mental illness rates remained relatively flat. So I think that was kind of some interesting idea of like the state of our country where we're at right now.
Well, and it's so important to keep these big studies going, so we can compare year by year and actually get a sense of what we're doing and if it's having an impact, So I'm glad we have that 2024 data and hopefully we'll have some 2025 data.
I'm still surprised by 78,000. I think that's a very high number I feel like we've made so many strides with treatment. It's still pretty sad.
It's sad. It's sad. I mean, it's better than it was, you know? But it's so many people and they're mostly so young, They're people with who have a lot to give and families, jobs, just the productive members of society. So we lose a lot when we lose someone.
Yeah, I feel like I don't know about you, but I feel like I sign a couple death certificates a year, someone that I was treating at some point. I also am their PCP and I just get a death certificate that they passed away, they overdosed. And it's always someone that's lost to follow up. And I always feel like it's always surprising. Sometimes it's the people I thought were doing the best. But I do always think it's such a waste.
Oh, totally. Totally. And totally what's sad is that it's preventable and yet so hard to treat. It's preventable
Yeah.
and yet not preventable as
Yeah.
we've seen.
How about you, Sonia? What have you been reading about?
Well, on a slightly more positive note, ASAM put out something that just makes me feel seen and understood. So we've talked about it before. I've been just struggling mightily with pharmacies and trying to get my patients their buprenorphine from the pharmacy. So every clinic, there'll be a billion issues with the pharmacies. Pharmacy doesn't have it. They won't fill it. Somehow the refill is too early. The patient has to go to 6 different pharmacies to find the brand they want. It's just so many issues with the pharmacies. And I've gotten into some real kind of conflicts with the pharmacists, which I don't want to be in because pharmacists are, doing a really, really hard job. And I'm grateful every day that they're there. And so I don't want to be fighting with them. But I have, and I've had to even file some formal complaints against some pharmacists for I feel causing harm to patients by refusing to fill prescriptions for ridiculous reasons. But so ASAM put out a toolkit for addressing issues with buprenorphine at the pharmacies. And I'll put the link to this toolkit in the show notes, but I was so happy. So basically, it's this toolkit, and for all the different issues you might come across, it tells you what they would recommend to do. So example, pharmacist declines to dispense buprenorphine for maintenance treatment solely due to the duration of treatment, telling you the patient's been on it too long. Or something more, the pharmacist declines to fill an early refill for a patient, and the patient has made multiple previous early refill requests. So what do you do in that situation? Pharmacist refuses to fill a prescription for buprenorphine because it was issued via telemedicine, or because it's a buprenorphine mono product and it's not a pregnant woman. And they sort of tell you what you should do and what they would recommend the pharmacist does. And one of the things they emphasize is that clear communication is really important. So if the pharmacy calls you, you should hop on the phone ASAP to talk to them and just try to allay their fears, explain what your reasoning is, hopefully come to an agreement. And that prevents delay in care for the patient and makes the pharmacist feel, like you're actually trying to work with them, and will help resolve the issue kind of one-to-one. But then if you can't get it resolved, ASAM has a sort of online reporting form they want you to put your problem into, and they're tracking issues with buprenorphine at the pharmacy so they can try to, collect some data and go for some larger advocacy, because a lot of pharmacists feel like they're under regulations that preclude them from filling scripts that even they know are legitimate. For instance, they can't get enough buprenorphine. They run out and they can't get more. Or they're told that a prescription is suspicious if the patient pays cash for it. And so they won't fill it if the patient's not using insurance, stuff like that. And so, to advocate for legislation that kind of absolves pharmacy from liability if they fill scripts under certain circumstances. So, John, do you feel like you run into problems at the pharmacy when you're trying to get buprenorphine scripts filled?
I don't feel like I have as many as I once did. I feel like you seem to be in some sort of conflict with the pharmacist a lot more than me. I do wonder though if it's also like the pharmacy most my patients get their scripts from is literally a mile down the road. And I feel like they probably know me relatively well. I think they know my practice patterns, and I think they know like what type of medicine I practice. So I don't think I get as much of that anymore. I think at one point I did, and it was kind of annoying, but I think that's really faded for me.
Yeah, I mean, I'm seeing patients from about a 50-mile radius over 3 counties, in rural counties, so people drive quite a distance, and I send scripts to, like, at least 20 different pharmacies, and there's always issues. And I feel bad, like, again, the pharmacists are really trying hard, and they don't wanna dispense illegitimate prescriptions, but I get issues like, for instance, I have a patient who's trying to go on a business trip to Baltimore, and he doesn't have time to drive home in wherever he lives and then go back to BWI before his flight for his business trip. So he wants to fill the script at a pharmacy closer to my office instead of closer to his home. And the pharmacist says that's a red flag. He's switching pharmacies. They won't fill it. I'm like, he's going to BWI. He can't drive back to wherever and then back to Baltimore. He doesn't have time. He has a flight. And they're like, nope, red flag.
Yeah, I mean, this is reactionary, right? We're Americans. We react very strongly to things. I feel like there's, large settlements from like Walgreens and some of these other pharmacies about kind of poor prescribing or poor filling practices that they contributed just as much as prescribers. And, maybe they did have some role in it, but I think now everyone's so afraid of like being like, accused of being a pill mill or something. But, I think we've gone now.
Rite Aid.
Yeah, now we've gone like to the other direction on some of this stuff, which is like, maddening in its own way.
Yeah. Oh, totally. So anyway, I'm going to put a link to this toolkit and then the pharmacy problem reporting form. And again, this is not to get pharmacists in trouble. This is to advocate nationally for regulations that exempt buprenorphine from being treated like other opioids in terms of pharmacy restrictions and regulations.
It's interesting.
So, yeah, it's super interesting. All right, John, you ready to tell us about your article?
Yeah, so I have a kind of an interesting article, kind of almost in line with my news article, kind of like state of our country in some regards. And so it's from JAMA Psychiatry from June of 2025. And the article's titled Prescription Stimulant Use, Misuse, and Use Disorder Among U.S. Adults Aged 18 to 64. And I guess kind of before I even get started, Sonia, I mean, do you have concerns or questions about stimulant use disorder like on the rise in terms of how we're prescribing and how we're treating and how these medications are being dispensed currently?
So I have concerns about stimulants in general. I have concerns about methamphetamine. I see a lot of that in my office. I have concerns about widespread overprescribing for stimulants, like without the appropriate diagnosis. What I am not sure about is the harm done by prescription stimulants. I don't know how that interplays with the methamphetamine epidemic. So what is the true harm of prescribing stimulants? Are those patients transitioning to stimulant use disorder? So that's what I'm not sure about.
Yeah. Yeah, I don't know. I think it's an area of interest, at least, or something I have an eye on. So a little bit of background here. So new stimulant prescriptions, they're counting that as amphetamines and methylphenidate for adults increased in the U.S. from April 2020 to March of 2022. So we've seen basically over the past 2 decades just steady decline in prescribing rates of these, especially to adults. There's concerns that include a lack of ADHD guidelines regarding formal assessment, misdiagnosis, overdiagnosis, overprescribing, the ramifications of psychosis with high doses, misuse, diversion, and then the development of stimulant use disorder, something that, is kind of iatrogenic, something we could have possibly caused. Previous studies have shown that ADHD medication has been protective in terms of mood disorder, suicidality, substance use, criminality, accidents, and mortality. And I feel like if I had to say the past 10 years, I probably have been to just as many grand rounds at this point about how I'm underdiagnosing and undertreating ADHD with stimulants as I have been overdiagnosing and overtreating. And I feel like I'm confused when I hear so many experts that are much smarter than me, and most of them psychiatrists, telling me that there's this dichotomous body of literature.
Well, and I feel that way too, because I also see literature about how people with a substance use disorder do better if they're prescribed stimulants appropriately and that they're not increasing overdose rates. So, like the safety of stimulants, but I feel anxious when this potentially addictive drug, I don't want to say is shoved down my throat, but it just makes me feel like it's the opioid epidemic all over again. Like propaganda saying how safe it is, patients wildly advocating for it, and me not being really sure how to diagnose adult ADHD.
So there's also concerns that limited access to prescription stimulants may actually push individuals to the illicit market where they're getting counterfeit pills, often containing things like fentanyl in addition to the stimulant that they're looking for, which raises overdose risk. Prescription stimulant use disorder is in the DSM-5 now. It's basically defined very similar to our other substance use disorders as impairment or distress linked to substance use, overdose, premature death, and the same criteria as we get for opioid use or alcohol use disorder. So the question really becomes, how can we balance kind of assessing the risk here, the safety, and also the benefit of these products in terms of adult prescribing? So the clinical question specifically in this study is, as stimulants are increasingly prescribed, what is the prevalence of prescription stimulant use, misuse, and prescription stimulant use disorder among adults aged 18 to 64? And this is in the U.S. specifically. So a little bit about the study. So this is a cross-sectional survey of 83,762 adults aged 18 to 64. And it was conducted between 2019 and 2022 using the IQVIA Total Patient Tracker and National Prescription Audit New to Brand database and the 2021 to 2022 National Survey on Drug Use and Health, so the NSDUH, of community-dwelling adults aged 18 to 64, and is examining the relationship between prescription stimulant use, stimulant misuse, and the development of prescription stimulant use disorder. Just to give you a little background of all those initials and surveys, so the IQVIA, the Total Patient Tracker and National Prescription Audit New to Brand database, is a database that captures approximately 93% of all outpatient prescriptions dispensed across the U.S. retail and mail-order pharmacies. So it's a pretty encompassing database of our outpatient prescribing. The National Survey on Drug Use and Health is an annual U.S. survey that collects representative data on tobacco, alcohol, illicit drug use, and prescription medication use, as well as mental health disorders in those ages 12 and above in community-dwelling U.S. citizens. And this is collected using in-person interviews and standardized questionnaires. And it's basically meant to kind of provide information to inform healthcare policy and programs. Very excitingly, 2021 to 2022 was the first year that actually prescription stimulant use disorder was surveyed. So it's the first year that we actually looked at it in the survey. So it's kind of a novel metric. In terms of what we were looking at specifically from measures, so they looked at prescription stimulant use, and this has included use as prescribed or misuse, so one of those two binary categories. Stimulant misuse was defined as any of the following in the past year, so using without a prescription of one's own, using in greater amounts than prescribed, using more often than prescribed, using longer than prescribed, using in some other way not directed by a doctor. They defined prescription stimulant use disorder via the DSM-5 criteria. They looked at other substance uses. They looked at misuse details as well. So this is kind of interesting. I feel like this is good information. Like, what was the actual motivation of the person for misusing? Were they looking to kind of like get some sort of like high off of it, or were they using it to treat an untreated ADHD? Like, they were trying to tease out, like, why do people not use their prescription as prescribed by a physician or an APP? They looked at mental health measures, so past year major depressive episodes, alcohol, and other drug use disorders, including nicotine dependence. They collected sociodemographic information about age, sex, race, ethnicity, self-rated health, ED visits, and suicidal ideation. They also, it can't be any trial in the past 10 years now without saying COVID-19 impacts. They looked at COVID-19 and how basically changes in how we receive care during that time frame may have affected stimulant use or misuse. They did do statistical analysis where they basically tried to adjudicate the prevalence and correlates of the prescription stimulant misuse and the prescription stimulant use disorder using this bivariable logistic regression. Any questions about this so far? So basically, it's a cross-sectional survey where they kind of correlated between the two prescription use and some of these findings.
Yep, no questions so far.
Okay. So is this a valid trial? So this was sponsored by NIDA, so from the NIH, SAMHSA, and the CDC. I guess this was still when SAMHSA was around. So there's no industry funding.
Sorry, SAMHSA, RIP.
One author reported stock holdings in General Electric and Pfizer. I love the fact they reported General Electric. It's very honest of them. I don't know if anyone would accuse a General Electric stockholder of relationships with industry.
I'm not sure how that's a conflict of interest.
I bet you if you dig down to it, maybe it does have some pharmaceutical bearing somewhere within it. But
I guess.
Very honest. It's a large cross-sectional survey of 83,762 adults. So it's not an RCT. It really precludes any kind of causal relationship here. This is really just kind of like information for assessment. I don't think you can kind of extrapolate too much in terms of causation or make any kind of massive practice-changing swings with this data. The NSDUH is a data self-reported survey and excludes unhoused adults not living in shelters and institutionalized adults. So basically, you're excluding your highest risk population right off the bat. So you kind of are selectively looking at kind of a population of lower risk, although not no risk, but lower risk than that other group. There's lots of possible confounders here. There's recall bias. There's a social desirability bias that, people provide results that they think people want to hear. Possible underreporting of misuse. And like I said, your higher risk subgroups have been kind of excluded. The IQVIA Total Patient Tracker and National Prescription Audit New to Brand database only contains information on dispensing histories, not diagnoses. I, as an adult ADHD prescriber, I do have patients I prescribe these to. It is interesting. I see a growing number of patients getting on stimulants from off-label use of these medications. I think oftentimes I see a rising trend of these prescriptions from sleep medicine. I think neurology for some of these fatigue-inducing disorders, I see that as well. So I'm seeing other reasons why people are on these than just ADHD. I'm not sure if you're seeing that too.
Well, I think like any medication that makes you feel good along several different axes, you can kind of come up with indications why you feel that it benefits you, and get on it for that reason.
I think in terms of prescription stimulant drug shortage occurred during this time frame. So this is a major limitation. So 2023 is one of these time frames where we had basically a shortage of stimulants. And so really some of those DSM-5 criteria, they might not be that useful in this type of setting. For example, 3/4 of adults reported drug use shortages that hamper their ability to get their treatment. So when you have questions like you're quote spending a great deal of time obtaining, using prescription stimulants or recovering, that actually might just be the fact that they had to call 13 pharmacies to get their ADHD medication. It might not actually be a misuse. And interestingly, in this particular trial, it didn't really vary by misuse status. So it probably wasn't really sensitive or specific for a stimulant use disorder in this trial. Strong urge to use, that could also be someone with untreated ADHD that's struggling at work because they can't get their medication. So.
Yeah, I feel bad. I'm complaining about the pharmacist with buprenorphine, but the poor pharmacist trying to deal with the ADHD medication shortage. What a nightmare.
Yeah, I feel like it's like, I don't know. I feel like I get a couple calls a day that like the pharmacy's out. Can you send something else? Go somewhere else. It's pretty tough.
Yeah, we had to sort of set a rule in our office. Our staff is no longer able to do that work for patients, call around, see which pharmacy might have Adderall. We were doing it for a while, but it just became overwhelming. We had so many patients we tell them, you'll have to call around and ask. We can't dedicate staff to this anymore.
Yeah, we did something similar. And then we actually got in trouble. And then I think now they'll let you do it. But yeah, I think we kind of jumped on that pretty quickly because we didn't have I couldn't lose 2 staff members calling pharmacies all day long out of my 6 staff members.
Right. To see who's got Adderall in stock.
Yeah. So, let's talk a little about the results. So he said before, almost 84,000 patients aged 18 to 64. When you look at kind of the breakdown here in terms of age spread from age 18 to 25, that was about 34%, 26 to 50, that was 53%. And interestingly, in this survey here, actually 56% were women, which is, they did talk about this quite a bit because, adult women have classically been kind of labeled as being underdiagnosed and undertreated with ADHD. So in some regards, they thought that was kind of positive that this group seemed to be catching up in terms of representation. In terms of trends, specifically in prescription stimulant use, so there was a significant increase in dispensing across nearly all age and sex groups. The largest increase was in that female, age 35 to 64, and it went from 1.2 million to 1.7 million prescriptions, so a huge increase during this period of time. In terms of past year prescription stimulant use, it was 7.5%, so 7.5% of adults were using prescription stimulants at some point in the past year. That's almost Ozempic numbers. Almost. In terms of stimulant misuse, among users, 25.3% reported misuse of their stimulant in the past year. So a quarter of people reported some degree of stimulant misuse with a prescription from their provider. The highest misuse was ironically women under age 25. So that was about 36.8%. And the lowest was women over 35. So it's like women were very, very low in this survey, like in that kind of underdiagnosed group, but then kind of under 25, they had a higher representation. Misuse was strongly associated with depression or suicidal ideation, nicotine dependence, other substance use disorder, concurrent prescription opioids, sedatives, or tranquilizers. Interestingly, patients that use stimulants and cocaine had the highest rate of misuse, so almost 64%. So that kind of makes sense since it's relatively similar spectrum there. Are you surprised by any of that?
No, I mean, I'm not surprised by the demographics or the risk factors for stimulant misuse. I'm kind of surprised the prevalence of getting stimulants was only 7.5%. I feel like more people than that seek them out. And if you look at like the, prevalence of adult ADHD, I don't remember what it is. It's like 5% or something, maybe. Then are all the rest of these people getting stimulants for, I don't know, excessive daytime sleepiness or what?
Yeah. I mean, I left this out specifically, but I'm going to say it now but without getting tribal. It was interesting that prescription stimulant prescribing rates were very different amongst the different types of providers. So, psychiatry and primary care were relatively flat. And actually, the huge explosion was actually from APP prescribing. And I'm not sure if that's just a factor that APPs are prescribing. Are they filling more roles in our healthcare society? Like, are we having more like psychiatric nurse practitioners providing this care? Are we having kind of more areas where we're kind of APP dependent? But there was a big jump in that one prescribing group, which I thought was somewhat interesting. I don't know what to make of that, if that's truly just a representation of their expanding role or whether there's something there.
I don't know. I mean, I think APPs are really filling a gap that is open in terms of care needs,
Yeah.
both mental health and primary care, especially in underserved populations and people who maybe other people, there's just not as much access. APPs are filling those holes. So I'm not surprised. I see a lot of APPs in mental health. There's just such a lack of
Yeah, it's huge.
psychiatrists,
I wish there was some data with it about like volume of prescribers. Like that would have been more, instead of just a total number of like an N, it would have been interesting to see like, prescribing per capita or some sort of like kind of equalizer for the volume, right? So just a raw number wasn't as useful. But this is a survey, right? So it's cross-sectional survey. So you're going to get information that you're going to have to kind of interpret. Interesting stuff here in terms of misuse, motivation, and sources. So 62% misuse to improve concentration or stay alert. So it seems like in 62% of the cases, so almost 2/3 of the cases, they're really kind of using the medication in at least in their mind to kind of seek a desirable effect for concentration or alertness. So not kind of the euphoric effect. In terms of those that did misuse, 68% had no past use misuse. So basically, this might be intermittent, that they're misusing the medication to some degree. Frequent misusers greater than 6 days per month were more likely to obtain their medication from theft or purchase than kind of people that were not frequent misusers. So it's almost 40% versus 21%. And individuals with prescription stimulant use disorder were more likely to obtain prescription stimulants from their physician than from buying them or from a family member, which I thought was very interesting. So almost threefold more likely to have a prescription from their own provider than from like an illicit source. That's surprising a little bit.
To me, that's not surprising because it seems kind of easy to go to your provider and ask for stimulants and get them.
Okay, well, maybe you're not. I'm surprised.
Not surprised.
In terms of behavioral health and substance use associations, basically the strongest cofactors for prescription stimulant use disorder and misuse was kind of co-prescribed sedative tranquilizer, so 60.1%. And people with opioid use disorder, they had a 67% rate of misuse. So very high rate for patients that are receiving prescription stimulants that also have opioid use disorder. You know, the COVID-19 impacts were kind of confusing to me a little bit. So it was kind of like talking out both cheeks. So basically, during COVID-19, when there was a shift of prescribing from in-person to telehealth, there was lower misuse among telehealth. However, there was more prescription stimulant use disorder among telehealth. So it's kind of like doesn't seem quite congruent. So I'm not sure what to make of that one. And I don't know if I'd make too much out of that alone.
Yeah, hard to know. But so wait, let me ask you about one of these previous statistics, make sure I'm understanding. So of patients with opioid use disorder who have prescription stimulants and misuse them, like they do something other than just take their medicine exactly as prescribed, of the misusers, 67% actually really misuse it and have prescription stimulant use disorder.
Now, so among the misusers, yes, among those that are misusers of the medication, opioid use disorder had the strongest association with prescription stimulant use disorder. So a step further. And so that was over 2/3 at 67.4%. So that group seems to be incredibly vulnerable for receiving these prescriptions.
Mm-hmm.
Does that make sense now?
Right. So of the people who, if you have opioid use disorder, it's more likely your 67% might transition from misuse to stimulant use disorder.
Correct.
Okay.
So if I were to summarize my biggest takeaways from this, so for anyone that kind of trailed off with all that listening, so largest increase in prescription stimulant use was women 35 to 64, a classically undertreated population in the literature. In terms of prescription stimulant misuse, a quarter of patients in the past year receiving prescription stimulants misuse the medication. In terms of prescription stimulant use disorder, almost 10% among patients in the past year that got prescription stimulants met criteria for prescription stimulant use disorder. And kind of concurrent opioid use was very likely to kind of transition over to prescription stimulant use disorder. Oh, and I missed one part. Interesting, which I missed one whole part. Amphetamines versus methylphenidate prescribing. Okay. So interestingly, there's higher rates of misuse with amphetamines than methylphenidate at 31.5% versus 10.5%. So I think that's a takeaway point too, that surprisingly the amphetamine had less of a misuse potential. And the same with prescription stimulant use disorder. That was higher with amphetamines as well compared to methylphenidate, 11.2% versus 5.1%. So I thought that was interesting because I've always thought that kind of amphetamines were longer acting, less likely to be abused, but that would point otherwise.
It would.
So in terms of will this help me in patient care, I think that this kind of puts some numbers to some beliefs I already had. I think that there is a degree of misuse and prescription stimulant use disorder that is most likely occurring in all of our patient panels. The question about it is how frequent is this really? And interestingly, those rates of 10% for prescription stimulant use disorder and almost 25%, they're not that far off from what I see most data regarding opioid use disorder. So I've seen data with opioid use disorder, about 10% of patients meeting criteria for opioid use disorder of long-term opioid users, and just shy of 50% meeting some degree of misuse. So higher misuse, but still the dependence is about 10%. I think that the findings really underscore that this is a problem that we probably do have to pay some attention to. And I think one thing I really struggle with is I don't really see a unified set of ADHD diagnostic practices or guidelines. I think I see there's a series of questionnaires that some people use. People go to ADHD.com and they'll pay $300 and take 4 questionnaires and get a diagnosis of ADHD and bring that to me that, they paid their $200 and that's considered an evaluation. I have some providers that they just kind of do a ADHD questionnaire in the office and that's kind of the diagnosis for adults. Some people go for neuropsych testing. I don't really see kind of a standard here or a true standard of care. And I think that, when you go off the DSM criteria, a lot of that's very subjective. It's hard sometimes to quantify. And the other thing about adult ADHD that's very different than childhood ADHD, where we have a lot of validated metrics, is it's often not by itself. So I think one of my favorite previous studies showed that adult ADHD, it's over 70% of the time there's a comorbid secondary diagnosis that's contributing to the clinical picture. So I think it's hard because, how can you really just evaluate one versus the other? So I think that it kind of underscores the need for some guidelines and some standardization there, especially as we have continued increased prescribing rates.
Agreed. And I mean, I'm not too shocked about the misuse statistic because that honestly encompasses behaviors I could see myself doing as well. Like, you don't take it one day and then you take extra some other day when you need to concentrate more on something, or I don't know. I see so many people sharing a pill with a friend. Not that I think that's good, but I just see it so commonly, and that's all misuse. But a pretty good percentage transition to stimulant use disorder. Even if it's mild or moderate, that's a pretty significant adverse outcome. What other meds can we prescribe where 10% of people have a significant adverse outcome?
Yeah, it is interesting. And you're right, the misuse, especially in that younger demographic. I mean, I think anyone that's been to college knows that I think those do get, those pills do make their way around the campus during exam times and things like that. And so that kind of makes sense. I think the biggest takeaway, though, is that a true use disorder in 10% is concerning to me.
Yeah. Yeah, and then we see people transition all the way to, full-on stimulant use disorder using non-prescription stimulants, cocaine, and methamphetamine. And that's sort of the worst outcome. And I don't know, this study, of course, didn't say how many people transition to that. Probably there's some overlap, though.
Yeah, I don't think they had that data. Not from this survey.
Well, it's really interesting, John. So is this going to change your personal prescribing practices?
It's so individual. And it's hard. I feel like a lot of my adult ADHD, the ones that I find a little bit more nebulous, often the diagnosis has already been solidified by psychiatrists, in which case I feel like a little less cautious about prescribing. I'm not sure if that's a great practice pattern. A lot of my new adult ADHDs, I do send for neuropsych testing. I've never had a report come back that they didn't have ADHD, but there's other stuff on there too that comes up, which is very interesting.
I'm surprised you got any report back at all. I had a personal record. I referred someone for neuropsych testing, and 2 full years later, I got the report back. I figured if the patient had enough organization to hold on for 2 full years, that was a good sign. I was like, I thought the patient moved to Florida. I didn't even know they were still my patient, and this report popped up.
The problem is it's hard. If you have private insurance, I don't find a difficulty getting those done in a timely manner. I think the harder group is people with state insurance that don't have resources to do one of the private testing groups. It's good information though. I really enjoy reading those reports because I feel like I learned so much more about the person because there's a lot going on. If you're diagnosing, if someone's coming to you at 45 for new onset ADHD, there's probably a series of things going on in their life. And oftentimes the report gives me a lot more information than my visits with them ever has given me.
Agreed. Those reports are awesome. Well, thank you, John, for presenting that article. That was really just interesting, and an issue that actually I think we deal with a lot day to day in primary care and addiction medicine. I did have some talk back I wanted to share with our audience. So it's about 2 episodes. So on episode 68, we read a comment from Dr. Eileen Barrett about the ethics of having a placebo in treating alcohol use disorder, and that was related to a paper in episode 65. So 65, we did a paper on varenicline and bupropion for alcohol use disorder, and there was a placebo, and then there was the treatment. And we had talked about whether it was ethical to use a placebo in a deadly disease like alcohol use disorder when evidence-based treatments actually exist. And so the authors wrote back to us and said, they're very aware of this. They said, we're aware of the ethical concerns with using placebo as comparator in medical research on new pharmacologic treatments when established effective treatments are available. So that was kind of our question as well. And they had 6 reasons why they had felt comfortable with this. And they had actually written this up for the journal. 1, in the case of alcohol use disorder, established treatments for harm reduction like acamprosate and naltrexone have but small effect sizes with a Cohen's d of 0.2, and a considerable proportion of published studies are in fact negative. So the established treatment doesn't even work that well. Number 2, FDA and the EMA, which is their ethical body or sort of accrediting body, still demand comparisons with placebo in the alcohol use disorder field. The majority of the AUD population receives no treatment at all. That was number 3. And the mere participation in a clinical study, also when receiving placebo, considerably reduces alcohol consumption compared to baseline levels, also observed in this study. So they're saying getting a placebo is actually helpful. Number 4, health consequences of alcohol intake are typically long-term, and the differential outcome between placebo and active treatment in terms of alcohol consumption during 13 weeks are unlikely to differentially affect the prognosis of this chronic disorder and its consequences. It's a fair point. Number 5, cases with severe health issues other than alcohol use disorder were excluded. Number 6, all participants received counseling at the end of the study and were referred to relevant caregivers. And number 7, this study was independently evaluated and approved by the Swedish Ethical Review Authority. So that was their answer to the question of whether or not it was ethical for them to conduct their study with a placebo. So, John, what do you think of their reasoning?
I mean, I think that all sound reasoning, right? I think it also speaks to how underwhelming some of our medications are for alcohol use disorder. Like if we were to play like Mad Libs here and put methadone or buprenorphine for opioid use disorder, I think that you would jamble this up. It would be no longer ethical, right? Because there's such a mortality benefit there. But I think all these make sense, especially kind of knowing the kind of current effect size we get for these medications for alcohol use disorder.
Well, right. That's the problem, is that the established treatments aren't that much more effective than placebo, actually. So, so I really wanted to thank the authors, Dr. Soder-Palm and team, for getting back to us with this explanation. I thought it was very helpful. We got one more comment about episode 65 I wanted to read about alcohol use disorder from Dr. David Rope. He emailed us and he said, interesting observations, especially related to the duration of the study, because again, this was like a relatively short study. Agree it would be nice to extend the trial, as the initial reduction in number of drinks over 8 weeks, followed by an increase in number of drinks, didn't seem to give enough time to see if lasting change was sustainable. So, and he said, as an aside, I wonder about the 3-month time frame correlates to early remission in the DSM, at least for abstention. So, I think in this study, right, it was like a 12-week study, but you could see rates of drinking actually started to go up again after 8 weeks. So who knows what would happen if you kept it going a little longer? Would people just go back to baseline after the initial inspiration to quit alcohol wore off? So who knows? We'll have to see. Stay tuned. Since we did that paper, John, have you used this treatment for alcohol use disorder?
In terms of what do you mean by that?
Like, have you prescribed varenicline and bupropion for alcohol use disorder primarily?
I have not. So, have you?
Yes, once so far.
Did it
Jury's
work?
still out. I don't know yet. Follow up TBD.
I'll be honest with you. This has just slipped out of my mind. I feel like it's I should try it, but I haven't.
I've been using topiramate preferentially. as sort of my first line for alcohol use disorder, actually.
Yeah.
Well, because it doesn't make you feel as sick. I mean, I'll use naltrexone as well, actually, especially for like targeted, like as needed, if people don't want to take something every day. But I'm finding topiramate to be effective, and the side effect profile is pretty good compared to naltrexone. So, but yeah, many choices. If there's too many choices, it means none of them are coming out in front, actually.
Yeah, I feel like I mean, it's always individual. I feel like I use a lot of gabapentin and naltrexone combined. Like, for the withdrawal sensation, it was like a Camprol-like effect, and then the naltrexone for the craving part of it. Although it's all it's part of the treatment. It's not the only treatment. And I think more so than anything, my alcohol use disorder treatment visits are like a lot of over teaching about that. Like, this isn't a medication only approach if you want to get those types of results. I think that I really, really drill in expectations with those visits more so than the other ones.
Agreed.
Well, thanks. That was great.
Yeah, thank you for listening. I want to thank you all for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation. We really want to hear what you have to say. So send us your opinions about the articles, comments on social media, email, join our Facebook group. Links will all be in the show notes. So our original theme music was composed and performed by Benjamin Kennedy. Audio editing by Michael Bonanno. CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.
Hey, Ryan Reynolds here for Mint Mobile. One of the perks about having 4 kids that you know about is actually getting a direct line to the big man up north. And this year, he wants you to know the best gift that you can give someone is the gift of Mint Mobile's unlimited wireless for $15 a month. Now, you don't even need to wrap it. Give it a try at mintmobile.com/switch.
Upfront payment of $45 for 3-month plan equivalent to $15 per month required. New customer offer for first 3 months only. Speed slow after 35 gigabytes if network's busy. Taxes and fees extra. See mintmobile.com.